Sherry put together this base. You're doing your own free will. Yeah. Go back.
Okay, I know it's not in
Yes,
convention mode,
that's
but
what
can you
Sherry
see
put
that?
Yeah, we can see it.
Okay, let me try to finish it.
Yeah, because there's
Seven, okay?
You got my number, right?
Okay, sounds great. I'll mute myself till.
All right, folks. Our next presenter is Dr. Laurie Halmo. Dr. Halmo is a medical toxicologist and an assistant professor of pediatrics at the University of Colorado School of Medicine and Children's Hospital of Colorado. In addition to her clinical work as a pediatric hospitalist and medical toxicologist, Dr. Halmo is also a volunteer faculty member at Rocky Mountain Poison and Advanced Safety, the region's Poison Control Center. She is also involved in numerous quality improvement initiatives related to the care of hospitalized toxicology patients, with a particular focus on children and maternal infant dyads affected by substance use and children in out-of-home placement, such as foster and kinship care. Dr. Halmo, I will turn it over to you.
Laurie, it looks like you missed your intro. Sorry.
It's all good. It came back, so we're all good. Hi, everybody. My name is Laurie Halmo. I am a pediatric hospitalist and medical toxicologist, and I work with Shannon very closely, so thank you for having me today. We are going to do a little bit of a rapid-fire overview of toxicology testing. And the reason I really like to talk about this topic is I feel like, you know, at least speaking from my own perspective, when I was in medical school and when I was a resident in pediatrics, I really felt like this was sort of assumed to be infallible. Like the results would come back and we would take those results as gospel, and if it said positive, then it was positive, and if it said negative, then it was negative, and that was the end of the story. And it wasn't really until I became a fellow in medical toxicology and started, you know, kind of learning more about these tests that I understood that that was completely inaccurate and really misleading. And led to probably a lot of problematic decisions on sort of all parts. So I think that, you know, it's an important topic, and I hope that I can sort of shed some of that light for you guys to just appreciate that these tests can be a little bit more complicated and sometimes more limited than we were necessarily led to believe. All right, so with that, what can a toxicology test tell you? Well, a toxicology test might tell you if a patient was exposed to a substance or a particular class of substances, but it is not going to tell you some really important information, things like who administered that drug, the route of administration, you know, was it inhaled, injected, you know, ingested orally, when the exposure occurred, how much of exposure occurred, what the dose was. It's not going to tell you whether or to what degree a person was impaired or intoxicated, much to law enforcement's chagrin. They ask me this all the time, and unfortunately that's just not something that these tests can tell you. And I can assure you that these tests do not tell you whether or not somebody is or was fit to be a parent or a safe caregiver. And yet I think we all have seen instances where that's functionally how the test was used to make that determination. So let's sort of dive into this a little bit more. I want to draw your attention to a couple of confusing terms because these get thrown around as if they are the same, and they're not the same. I want to just first of all clarify the process of screening for substance use or substance use disorders and testing for substance use or substance exposure. So screening is when you talk to a patient or a client and you just gather information. You might use a validated screening tool. And, you know, in my world, in the world of sort of, you know, pediatrics and perinatal toxicology, you know, we really advocate in the medical setting for all pregnant and birthing people to be screened for substance use using a verbal screener or a written screening tool. That is distinct from testing. Testing is when you collect a sample, you know, a biological sample, whether that's, you know, hair or urine or blood or saliva or whatever the case may be. And you send that sample to a lab and you assess for the presence of a substance or its metabolite. Really important thing that we're not going to dive into today because we don't have time, but more from just a pragmatic perspective for you to understand from a hospital's perspective or a clinic's perspective on the medical side, we do not routinely test everybody that screens positive. Mostly because it's not useful, right? If a patient tells me I use fentanyl every day, I probably am going to find fentanyl in their urine. And that's pretty much all I need to know, right? And most of the time, if you have a skilled clinician, you can get a pretty accurate history, and so we don't always need testing, but sometimes we do. So the scope of when we test and when we don't test it in a medical setting is obviously not as relevant to you guys. I just want you to understand that we often get patients that screen positive, and we don't always test them every time. So just be aware that that is, kind of the reality of medical care. Now, why are those terms so confusing? Well, the reason it gets really confusing is because within the testing bucket, that second bullet point on the last slide, there are sort of two big types of tests out there, two big categories of tests. And they are called screening tests and confirmatory tests. And so you can see how this gets confusing, right? A screening test versus the process of screening, which I just told you is not the same as testing. The words get really confusing, and I wish that we had different terminology, but this is what it is. The fact that we separate screening tests from confirmatory tests, though, that is a really important distinction that I want you guys to understand. And if you take nothing else away from this lecture, I want you to understand that there are two types of tests out there. These are the two types, and that they are distinct. And understand some basics of what makes them distinct and why that matters. So on the left, our screening tests are what most of us think of when we think of sending a drug test. This is this standard pee in a cup, and it gets sent to a lab, or sometimes it's actually done right there by a nurse or another tech. They'll dip a little stick into the urine, and the stick will change colors in a certain way, and that is how you read out the results, is based on this colorimetric change. That's what we call a point of care, or a sort of a rapid analysis. You can also send it to a laboratory, and the laboratory will do an analogous process. But the point here is that these screening tests, which again are most of what is done when it comes to toxicology testing in the US, broadly speaking, for any reason, these are usually immunoassays. That's the sort of style of test, or sort of the chemistry that's happening. Immuno, that word, means it involves an antibody. An antibody is just a protein that is made in a lab, and it is designed to bind to something very specifically. And so I explain to people this is a lot like having two puzzle pieces that are designed to fit together. If you have, the puzzle piece A and puzzle piece B, and they're designed to fit together, and they meet up, in real life in this test tube, then the test will read out positive. If you have puzzle piece A and there's no puzzle piece B being the drug in question, then you will have a readout of negative, and that's how these tests are supposed to work. The problem with these tests are that, first of all, they're usually qualitative, not quantitative. So they'll tell you present or absent, positive, negative, yes, no. The pieces fit together or they didn't fit together, right? It doesn't give you a number. It won't tell you there were 2,000 nanograms per milliliter of morphine present in this patient's urine, which is just a limited piece of information, right? And more importantly, these tests are riddled with false positives and false negatives, and we're going to get into the details of that in a minute. Where this comes from on a basic level is, I don't know if any of you guys have ever done a puzzle, an actual puzzle with a young child. I have 3 young children, so I do lots of puzzles with young children. And they are experts at getting two pieces that were not designed to fit together to smush together somehow. And it's any given piece in the puzzle, they can find half of the other pieces will smush in if you try hard enough to make it fit. And that's sort of what happens in these tests when you have a false positive. You have the original puzzle piece that was designed to match with this other piece, but in fact you have some third thing in the mix that it was not designed to meet up with or match with, but in fact a bond forms, and this chemical bond still forms, and that leads to a false positive result. So we're going to talk about this ad nauseum, but I just want you to understand that that's in the context of a screening test. If we have so many false positives and false negatives, why do we do these all the time? I told you these are the vast majority of tests that are done. We do them so often because they are cheap, they are fast, and you can get one anywhere in the world practically. That is in contrast to this other whole bucket of confirmatory testing. The details of how these tests are done probably doesn't matter to you guys so much, but just understand that it's a completely different chemical process. It uses completely different technology. And some of the types of analytical techniques are referenced on the slide here. So HPLC, GCMS, LCMS. Again, the details of that doesn't really matter to you, but if you see those types of initials on a report, you can infer that this was a confirmatory test. In case anybody's like Googling in the background, HPLC stands for high performance liquid chromatography, GC stands for gas chromatography, LC stands for liquid chromatography, and MS stands for mass spectrometry. So these are sort of combinations of chromatography and mass spectrometry. Again, details don't matter. Understand that the chemistry is totally different. There's no puzzle pieces involved here. These tests yield very accurate, very precise, quantitative results. So it's a way clearer picture of what's going on. But these tests are really expensive. They're really slow. They can only be done in very specialized laboratories. So like your average hospital or clinic lab cannot do this test. You need specialized equipment and specialized personnel. So they have to send the sample, literally send it like in the mail, to a reference laboratory, typically out of state. Takes a long time for that to arrive at the facility, then for it to be processed, the test to be done, the results to come back to you. By the time the whole thing is done, you've spent a lot of money and maybe had to wait, a week or two for results. And in a medical setting, that's usually not very useful, right? By the time a couple of weeks have passed, my patient is either better or dead. That's not really useful to me. But the accuracy and the precision is far, far beyond what you get with a screening test. So that's the basics of a screening versus confirmatory. Now let's dive in here a little bit. I want to focus more on some of those urine drug screening tests because that's that left-hand category. Because again, that's the vast majority of what's performed in the US for any reason that you're drug testing today. And I want to highlight a couple of facts for you guys. Fact number one, what you find depends on what you look for and where you look for it. I'm going to explain what that means in a minute. We're going to talk a little bit more about cross-reactivity. This is that false positive thing that we were talking about before. And we're going to talk about the fact that there's actually a threshold or a minimum amount of drug or substance that's necessary to be present in order for the test to read out as positive. So this is how sometimes you can end up with both negative results. And again, I'll show you this in just a minute. Okay, so what you find depends on what you look for. I'm just giving you an example here. These are 3 hospitals where I work. If I go into a patient's chart and I order a urine drug screen, and I'm at Denver Health, or I'm at the University of Colorado Hospital, or I'm at Children's Hospital Colorado, I am going to get a very different test that is performed, even though I ordered the same thing. That's because there is no such thing as one urine drug screen. There are dozens of manufacturers that make dozens of different products that each test for different things, and they use different actual antibodies or different puzzle pieces to test for sometimes the same thing. So one thing to just understand is if you are talking to like a hospital or you get a drug test on somebody for whatever reason, do not assume that you necessarily know what they're testing for. You have to actually look at the readout to see what was tested for. And clinically, people make this mistake all the time, right? If I'm working at Children's and somebody calls me to transfer a patient from Denver Health and they're telling me about the patient on the phone and they say, okay, this is a patient and they were found down and we don't know what's going on, but we did a urine drug screen and it was negative for everything. Well, I'm over here at Children's thinking, oh, it was negative for these, 15 different things that are on my urine drug screen here at Children's. But actually at Denver Health, they only test for 5 different target analytes, only 5 different things. So they didn't do as comprehensive a test as I'm assuming they did. And that's a problem, right? Because now I've misinterpreted those results, right? I've given more credence to what potentially is there. And in fact, they didn't test for quite a bit that I assumed that they did. So it sounds simple, but just understand, not all these tests are the same, right? They test for different things. Other common mistake I see amongst very established and very experienced medical providers is people mistakenly assume that if you use an illicit drug, it just goes everywhere in your body. But that's not true, right? We actually kind of already know this, right? Like if you think about a patient that's getting chemotherapy, we know that chemotherapy does not affect every cell equally. If chemotherapy killed every cell equally, patients would never survive chemo, right? They would just die. But actually chemotherapy doesn't go to all parts of the body the same. It targets certain cells in certain parts of the body more than others, and that's how people can, get remission from cancer and also survive their chemotherapy. The same is true of any other pharmacologic agent, any other drug, whether it's prescribed or non-prescribed. Drugs do not move through the body equivalently throughout all tissues. And this is really important when we talk about newborn testing. The reason is that newborn testing is somewhat unique because we can test certain samples that aren't really testable in other populations, right? We can test umbilical cord tissue, right? There's no other population outside of newborns that are going to have umbilical cord tissue laying around for you to test, right? You can test meconium, which is baby poop. And again, you're not going to be able to do meconium testing on really any other population. But the problem with using umbilical cord tissue and meconium is that because those are specific to newborns, we don't actually know very much in the medical community about how drugs get there or maybe don't get there. We just don't know. It's such a limited population, right? And so we just don't know necessarily whether or not we should expect to see fentanyl or oxycodone or cannabis in an umbilical cord tissue sample or a meconium sample. And in fact, when we look at data, so this what you're looking at on the slide is a study where this investigator took paired samples, so same baby, but looked at umbilical cord sample from that baby and meconium from that baby. And then they looked at, hundreds of babies, right, where they took paired samples, umbilical cord and meconium, each from, each baby. And then they compared them and said, how much do these align or not align? And the answer is, the alignment is terrible, right? There are cases where we have, tons of drug present in the meconium, and the umbilical cord tissue reads out as negative, and vice versa, right? And you can see that delineated here. Just to make sure people understand, this is, even though it says negative positive on the umbilical cord tissue, on the bottom part of the graph, that is not an immunoassay. This is not a problem with false positives and false negatives. This whole experiment was using those very accurate, very precise, very expensive techniques to get very accurate results. The problem is not the test. The problem is that the drug just wasn't present in a lot of these samples, even though it was present in its, reciprocal sample from the same baby. So again, just speaks to the limitations, right? Drugs don't go everywhere in the body equally. This is sometimes how you can have a patient with real exposure but test negative. This is a study that just demonstrates the same thing in a different way. What you see here are twins, right here, twins that were drug tested, and the twins had different results. Two sets of twins with different results. So again, just points to the fact that this is an area of medicine that is very poorly understood, and we don't exactly know why those twins had different results, but they did, which is a little disconcerting when you think about how sometimes we interpret these, right, as being true with a capital T. Well, these two twins presumably had the same exposures in utero, but they had different test results. So let's switch gears a little bit, and I'm kind of moving at a fast clip, but I want to get through this, to look at cross-reactivity. So this is where you can get false positives from. And this is just an example to show you how this happens, right? We talked about how if you have those two puzzle pieces and you have a third piece that looks sort of similar, but not exactly the same as the piece that it was supposed to, kind of fit with, you can have the pieces that are not intended to fit together actually fit together, and that's when you get a false positive result. So this is what this looks like chemically. So if you have a test that's looking for morphine, most opiate screens, by the way, are actually designed to look for morphine, even though they don't tell you that. If you have a test that's designed to look for morphine, and the patient in fact has hydromorphone, which is not morphine, but looks very similar to morphine, you can get a false positive result, right? You can get a test that says, oh, I found morphine, but it actually didn't. It just found something that was similar to morphine. In contrast, you're not going to get that false positive result with fentanyl, even though fentanyl is also an opioid, because the chemical structure of fentanyl is too different than, from morphine or hydromorphone for that false positive interaction to occur. And in fact, this is where people get confused, right? They see an opiate screen that says negative, but the patient is in fact taking fentanyl. Why does that happen? It's because the opiate screen is designed to look for morphine, and fentanyl and morphine are too dissimilar chemically. They will not show up. Fentanyl will not show up on a morphine screen or on an opiate screen. If you want to screen for fentanyl, you have to get a fentanyl screen. So now people are starting to understand that, and they will sometimes send specific fentanyl screens where the antibody is designed to actually look for fentanyl specifically. Now, let's take a look at those fentanyl-specific screens, right? So now we're talking about using an antibody that is designed to look for fentanyl, which is this guy right here. Well, it turns out that actually the fentanyl-specific screens have a lot of false positives too. Here are two examples of other drugs that people take not infrequently, trazodone and loperamide, which is in Lamodal, if anybody didn't know that. And these two, other medications have known cross-reactivity with the fentanyl assay because they are too chemically similar. They're not as similar as morphine and hydromorphone were on the last slide, right? You can probably see these are not as obviously similar, but this is how actually poor some of these immunoassays are. This degree of similarity, if you want to call it that, is enough that actually having trazodone or having loperamide in your system will make you have a positive fentanyl screen at times. And the problem is beyond just those two drugs. This is a list of what's been published so far of medications that we find can in fact cause a false positive urine fentanyl screen, and the list grows every day as we discover more and more of these. So let me give you just some numbers so you understand how significant a problem this is. Again, the details here don't matter. What I want you to see is that this is looking at 2 brands of fentanyl immunoassays, so rapid fentanyl urine screens, 2 brands. The brands are called ARC and Cephria. And then they compared these immunoassays, these 2 brands, against the gold standard, which is LCMSMS. This is that confirmatory method. So this is a sort of true result. This is what the kind of rapid, urine screen would tell us. And if you do the math, here's a second study, same design. If you do the math, it's about a 10% false positive rate if you use the ARC. That's like 1 brand. ARC 1, ARC here is the first generation, ARC 2 is their second generation, which is a slightly modified test. It's about 10% of patients that will have a false positive result, which, it's not overwhelming, but if you're talking about, screening hundreds or thousands of patients, that's a major problem, right? You think that's bad. The Cephria is horrible. It's like somewhere between 20 and 45% false positive rate, right? So these tests are designed to be really sensitive. They pick up a lot, but they're not very specific. They have lots of false positives. And so again, it's not that it's a useless test. You just have to understand what the limitations are in order to be able to interpret it correctly and then, make decisions appropriately. So that's just looking at the fentanyl, only the fentanyl immunoassays. This is looking at amphetamine, so a different part of the urine drug screen. And this is just to demonstrate that different companies use different antibodies, and different antibodies have differential specificity and sensitivity to other related compounds. So just like we were looking at before with the ARC and the Cephria, 2 brands with pretty different false positive rates, right? Like one is like 10%, one is somewhere between 20 and 45%. This is, looking at different companies that are doing amphetamine screening. And look how different the numbers are here, right? The details don't matter. What I want you to see is how different they are, right? So what can happen is you take the same patient's urine, you have a patient pee in the cup, and then you send that pee into 3 different labs where they use 3 different companies' tests to do the same thing, to do an amphetamine screen or do a fentanyl screen, and you might get 3 different results, which is a little bit disconcerting, right? But again, just a limitation you need to be aware of. Okay, just to understand the scope of the problem, this is to show you how many different potential medications can potentially cross-react or cause a false positive within different categories of target analytes or things we test for. So amphetamines, methadone, PCP, or benzyclidine, TCAs, right? This is not an all-inclusive list. This is not even an all-inclusive list of things that we test for, much less an all-inclusive list of the things that cause false positives for the things that we test for, right? But look how large this list is. This list includes things that are prescribed to the patient that we want them to take. We want them to take their bupropion for depression. We want them to take their ADHD medications so they can function. It includes over-the-counter medications like decongestants that the patient may not even think about, oh, I took the decongestant 4 days ago. I wasn't even thinking about that when I peed in the cup today, right? It contains supplements or herbals that patients may not even think of as being medications, like Mawang, which are legal. but can cause an amphetamine screen to be positive, right? So you can see again how very complicated this gets when you're trying to understand and you see a positive result in front of you. Is this a true positive or is it a false positive? And how do I know what the patient's been taking for the last several days? It's really hard sometimes to get to the bottom of this and interpret it correctly. Okay, we talked about false positives earlier. I just want to call out that false negatives also exist. This is the same couple of studies we were looking at before, but instead of looking at the false positive rate, we're looking at the false negative rate. False negatives are generally rarer, but they still happen. So here, Cephria, which had that horrible false positive rate, has a low but not zero false negative rate. So the false negative rate is about 1%, which again, not horrible, but if you're talking about screening, sending a screening test on hundreds or thousands of patients, now you're talking about some folks that are gonna falsely screen negative from this particular test. Okay, last thing I want to say about false negatives, just so you guys understand. Again, there is a threshold or sort of a minimum amount of drug that has to be present in the sample for the sample to read out as positive. What that threshold is actually determined by the laboratory's medical director. So it's a single human being who decides where the line is. Now, that person might decide to use the line that is recommended by the manufacturer of the test, or they may decide to use a different line. And they don't necessarily have to explain to you what their rationale is. Just so you guys are aware, many manufacturers of drug tests will recommend specific cutoffs or thresholds for positivity, and they are getting their thresholds from the Department of Transportation, the US DOT. The reason being that the workplace drug testing, which is sort of where drug testing originated in Vietnam War for military individuals, and then sort of bled into workplace testing specifically for long-haul truck drivers that are employed by the DOT. Those tests have to be sort of very stringent in terms of how they are interpreted, because you're talking about somebody losing their job if it gets misinterpreted, right? And so the DOT has set thresholds, which are listed here, which are, again, for workplace testing, not for medical testing, not for child welfare. This is workplace testing. But because manufacturers want to be able to sell their test to places that do workplace testing, they will often recommend aligned cutoff values. So they will sort of borrow these for their manufactured assay or their test. And then hospitals or courts or whatever the case may be may borrow those and take them with them. But these cutoffs were never actually designed to be appropriate for court involvement or for medical care. And so it sort of calls into question, are these really the right numbers? Hard to say. They are often the numbers that are used, but it may not be the most meaningful cutoff. And yet, here we are. So what does that mean? Well, it means if you have a patient that in fact takes morphine, and their morphine concentration in their urine was 1,995 nanograms per ml, that test is going to read negative, even though it's really present, because it's under the cutoff of 2,000 nanograms per ml. And this is how false negatives can happen. Okay, with that, I'm going to wrap up because I want to leave at least a minute or two for questions. Where do you go if you need help? If it's 2 o'clock in the morning and you need somebody to help you out, where can you go for help to interpret these tests? There are 2 options. Those of you that have done anything in workplace testing may have heard of something called an MRO or a medical review officer. Long story short, these are specially trained physicians who know how to interpret these tests, but they cost money. So an MRO review is not free. So unless you have a funding source that's going to pay for an MRO review, that's probably not an option for you. Also, just know that MROs primarily interpret workplace testing. So they don't do much newborn testing because newborn testing is not part of the workplace, right? So they don't really have a lot of experience with newborn testing results. But for adult testing, they can be very useful if you have funding. Laboratory staff are very knowledgeable about this, as are medical toxicologists. And a phone call is always free, whether it's to the lab or to the medical toxicologist on call. And there's the US Poison Control Center number where you can get a toxicologist on call 24/7, 365, free. You can always look stuff up if you want to, but realistically, I would suggest calling a toxicologist and having them pull a product manual, a test directory, or search in PubMed for you, because they're going to be much more accustomed to doing that. And with that, I will wrap up. And if there's time for questions, I'm happy to take any. I understand if there's not. Thank you guys.
Thanks, Laurie.
Do we have any questions in the room? Oh, we do have a question up here.
The medical toxicologist mentioned on the last slide, can she share who employs them? Can you hold on for just a second while you get the mic, please, for our question? Thank you.
I was curious, the medical toxicologist mentioned on the last slide, who are they employed by?
Dr. Halmo, the question is, on the last slide of the medical providers, who are they employed by? I'm assuming you're talking about the MRO.
Yeah, the
Folks.
medical toxicologist number.
It's the third one, not the MRO, it was the 1-800 number.
They'd like to know the 1-800 number on your last slide. Who employs those individuals?
Yeah, great question. So full disclosure, one of those is me. So medical toxicologists are employed by lots of different entities around the country. Some are employed by hospitals, some are employed directly by poison control centers, some are employed by private, groups. As a general rule, if you're taking call for a poison control center, the poison control center is going to be getting some federal funding. That's sort of typical. And even though the individual is funded, typically speaking, like myself, for example, I don't make any money. Like, I'm a volunteer faculty at the Poison Control Center, and the vast majority of our faculty, we're, this is a Colorado-specific group. So Colorado's Poison Center is the Rocky Mountain Poison and Drug Center, which is here in Denver. It's where I work there, but I'm a volunteer faculty there. So I don't make any money working there and taking call. But it's a really important public health service, and so myself and like 25 others, all of us medical toxicologists take call for free there, and we do it because it's important, and that's not an uncommon situation. So most of the time there will be a small staff that's funded and then a much larger staff that is unfunded. I still have a job that's paid, but it's not my poison center position. I don't know if that answered the question you were asking, but
We got a thumbs up. Do we have any other questions? Well, Dr. Harlow, thank you so much for joining us today. We appreciate the information, and we will be sharing her information out as presented today at the end of the conference. So thank you so much again, and let's give her a round of applause, folks. Okay, so we're going to take a 10-minute break. We'll come back. It's a little less, about an 8-minute break, and we'll be back at 11:10 with our next presentation.
Do you want me just to keep the mic back there?
Yeah, because we've got the second one from here.
So if I can just do it.
Yeah, as long as that other the mic is not on, we can.
Okay.